Hey everybody, I'm Jake Woodrich. I'm here to tell you a little bit about ACL injuries and how we should know when our patients are ready to return to sport, return to play, or return to practice. Are they ready to play? So I want to start out with a case study and have you take a look at this here. So there's a 20-year-old Division I college football player coming to see you. 7 months post ACL reconstruction, there have been no complications after surgery. His season starts in a month. He's a running back, and he's hoping to get back to practice as soon as possible so that he can be out there to start the season. Um, his team is practicing, and they're getting ready for the season here. The orthopedic surgeon cleared him for football activities. He's got 5 out of 5 MMT strength in the quads and hamstrings, and he has full active and passive range of motion. There's no swelling or pain at this point. And now, what are some ways that you can look into this to see if he's ready to play? And some of the ways in the past that we thought about this, we wanted full symmetrical range of motion. We wanted no swelling or pain. And we wanted a limb symmetry index of at least 90. So we're looking at hop tests, quad strength, hamstring strength, different tests in that way. Is that limb symmetry index 90% from your operative side to your non-operative side? So based off of this, is he ready to play? There's a problem though. Up to 30% of young athletes suffer a second ACL injury in the few years after they return to sport. Within 5 years, up to 50% will suffer a meniscus injury. We can be better than this. And I think a lot of the reason that those injuries occur could be that they're just not ready to return to sport. So what can we do to ensure that they are ready to return to sport after the rehab process? And how do we integrate the rehab process into a return to sport level? So the one thing that we want to make sure is that they are mentally ready for this. The main reasons that players did not return to play were lack of trust, fear of a new injury, and then there's also poor knee function. But to look at those first two, the lack of trust and the fear of a new injury are super important. And obviously that's more psychological than it actually is physical. So while we are physical therapists, it's important that we build into our program a way for them to trust their new knee, a way for them to trust that they aren't going to have another injury. Multiple studies cited patient confidence in this return to play criteria. So a lot of studies looking at return to play criteria, several of them said that patient confidence is super important in that return to play process. So what are some factors associated with them being ready to play? For one, high self-efficacy, an internal locus of control, and a low level of fear are associated with a higher chance of return to play. So we're talking about them feeling in control, not having fear that they're going to have another injury, and then having control over their body, having control over their knee, feeling that they're in control of their different movements as they return to sport. They also found that males, younger age, shorter time between the injury and surgery, higher frequency of pre-injury sports participation, greater limb symmetry, and then higher subjective knee scores also correlated with being mentally ready to return. If you think about that, a lot of that makes sense when you're thinking of higher frequency of sports participation before the injury. So they're used to playing. They've played for a long time. They've not had maybe many injuries before this. And the more they had that, the more experience they have, the better they're going to feel about returning. Super important here, that next bullet, athletes' belief in the rehab program. They need to believe that they're getting to a point where they're ready to return to sport. And if they don't believe in that, they're not going to be ready to return to sport. They need to believe that injury is healed. And some of that's going to come from the surgeon, from the doctor, but it's also going to come from your reassurance. It's what you're doing with them in the rehab program. It's what you're doing with them when you're checking their motion, you're checking their strength and everything. They want to see that injury is healed. And they also have to be confident they can perform at that pre-injury level. Nobody wants to go back and be worse. They want to go back and help their team and be better. So what can we do at the rehab level to make them confident? How can we make them feel that they're going to be able to perform at that level that they were before the injury? How can we measure this readiness? So the anterior cruciate ligament return to sport after injury scale, the ACL RSI, it asks some questions about fear and confidence in the return to play process. And they did find that participants who scored lower showed a decreased readiness to return to sport, and I believe it actually showed a decreased return to sport level as well. Another thing we want to look at when we're figuring out if they're ready to return is how long has it been since that surgery? What's the timeline here? So timeline's a big thing, and people have always looked into it. And obviously, the timeline has gone down as surgeries have gotten better, the grafts have gotten better. Uh, but what they found is that there is an 84% reduced risk after 9 months. So if you hit the 9 month mark, you have an 84% reduced risk of an injury at 9 months. After that, no further risk reduction of an injury. So 9 months seems like that number that you really want to get to. But they did find that after 5 months, up until 9 months, every 1 month delay in return to sport was associated with a 51% risk reduction. So each month after that 5 month mark is massive. Any extra time you can get in there is huge. There were a few players that returned prior to 5 months. All of them suffered re-injury within 2 months of return. So not great rates, less than 5 months there. So how's their strength? That's another thing we want to look at when we're looking at return to play protocol. Isokinetic testing is often used. It's expensive. It's difficult. Most clinics are not going to have it. But with research purposes, they did take a look at this. Before a return to run, so this is not just a return to sport, this is before they're returning to running, which again, you have to be able to do if you're going to be practicing, or even before you're out there returning to sport. And in a running sport, you have to be able to run. They wanted a limb symmetry index of greater than 70% with both legs. They said that less than 10% quad strength deficit to hamstring strength is also super important, because every 10% decrease in that hamstring to quadriceps strength ratio, there's a 10.6 times higher risk of sustaining an ACL graft rupture. So we really want to make sure that quad strength is strong. And that's one of the first things that we're going to try to get back after ACL surgery. We want to continue to make sure that we're working on that quad strength throughout care. A quad strength deficit showed to be a higher predictor of re-injury. Every 1 percentage point increase in that strength symmetry of the quads to the hamstrings, 3% injury rate reduced with that. An asymmetrical quad strength, not only is it important just because of these numbers here, but there's also asymmetrical biomechanics with hopping when you don't have that symmetric quad strength from side to side. Another really important thing, perhaps maybe even the most important thing when we're looking at return to sport, is how do they perform these functional tasks? How do they perform the movements that they're going to have to perform in sports? Movement quality deficits, especially those movements associated with sport, are associated with higher re-injury risk. I don't think that that's rocket science, but we have to make sure that we're looking at these things when we're watching them with the rehab and testing them before they do get back to practice in sport. A couple different tests that you could use that have data and values behind them: single hop, triple hop, and the triple crossover hop test, which I'll show you in a little bit. We want to see that the index between these two, all of them are on single legs. So you want to make sure that limb symmetry index is greater than 90%. And that's based on the research and the different literature showing that 90% LSI from your repaired side to your non-repaired side is an important benchmark to get to before they return to play. A few other tests you could use that do have some measures with it, but also just to evaluate their movement and look at it, whether it's via video analysis or just by the eye. The Y balance test and the single leg squat or the step up are different functional tests you can have them do, along with the vertical jump and the drop jump, which studies have shown actually have very similar knee biomechanics. So you could use either one depending on the sport, what the athlete's able to do, what the athlete is required to do when they do return to sport. They also found that the T-test being less than 11 seconds had a high correlation of people being able to return to sport with a reduced risk of injury. So a quick note on limb symmetry index. It's frequently been cited, and we cited it a few times in some of the past slides. And a lot of people use that 90% or that 70% as a metric to get back to return to play or return to run. The problem with this is that the uninvolved limb has decreased function. It doesn't get used as much while they're going through the rehab process. They're not out there playing football every day. They're not out there playing soccer every day or basketball or whatever the sport may be. So you're going to have a decreased function just from not using it as much. So is it really fair for us to compare something to something that isn't what they were normally using before. If we want to get to them to that pre-injury level, should we be using something that's not even at their pre-injury level to see if they're at that level? So they found that 40 of 70 patients in this one study met the return to play criteria with the HOPS 90% LSI. So these 40 out of 70 are meeting this 90% LSI mark that we talked about. But only 16 of those 40 patients met their 90% estimated pre-injury capacity. So this pre-injury capacity, they calculated it based on what they would have expected them to be before surgery. They had some measures that looked at it before surgery as well with what they could do. And not all of these patients are meeting that. And it was a better predictor of second ACL injury. So those 16 that meet that are in a better spot than those other 24 patients that did not meet that criteria. So are we really doing best by our patients if we're using limb symmetry index instead of looking at some other measure from before the injury where they really were at the capacity they wanted to be at? So is there a better way to do this? I think the best way is having preseason testing measures, and that's sometimes very difficult, especially as a physical therapist. If you're seeing these people just after injury, you're not going to have this. But teams, encouraging teams before the season to take some of these measures, take a HOP test before the season, do a Y balance test before the season so that we have something to compare it to once this happens, if this happens. That's another reason why we want to test it before the season. If you're seeing these people year round, if you have strength and conditioning staff on hand, doing these kind of measures before the season, I think is super important. But if you can't do that, and odds are you're probably not going to be able to with everything, another way to do this is take some measures early in the rehab process on that uninvolved leg, as long as it's safe. And this is mostly going to be with strength, not probably doing many hops on the uninvolved leg, just for safety reasons at this point. But early in that rehab process, get a feel for their strength on that other side so that you're at least having something to measure it against later in the process that's more reliable than something that hasn't been used as much as it normally was before the injury. The last thing we really want to make sure that we're looking at here before they return to play is, have they built up that chronic workload? Building up a chronic workload is often cited in cases of re-injury or new injury with the return to sport. You have to have that chronic workload. They have to be ready to play. So how long have they been rehabbing? How much sport-specific rehab have they been doing, and how often are they rehabbing? And I think this is really important. If you're looking at it, they're practicing 5 days a week. Let's say they're practicing for 2 hours a day. And if you've just been rehabbing 3 days a week, 2 days a week, and they're only coming in for an hour, and really for that hour, maybe they're only actually doing work for 40 minutes of that, are we really building them up to be ready to return to practice? Or is it all of a sudden going to be a massive ramp up really fast? So we got to make sure they build up this chronic workload, and that takes some time. We need to simulate this in the rehab setting the best that we can, whether it's working with trainers outside, strength conditioning staff outside of what we're doing. We want to make sure they're getting this chronic workload so that when they do get back into practice, they do get back into games and game settings, that they are ready to handle the different workloads that they're going to be taking on. So let's revisit that case study that I showed you before, and I want you to think about it this time in a different perspective. Now that we've gone through some different things, we've talked about some of the different strength measures, the psychological readiness, the chronic workload, the functional drills that you could take them through. Think about all that stuff, and let's revisit this case study. And I'm going to have you pause it here on the screen. I want you to pause it here, write down 5 things that you could do with this patient, different tests, different measures, or what you're going to make sure that you have done with this player so that you know he's ready to return to sport. Okay. Now that we're back, you paused it, you went through, hopefully you wrote down 5 things that I wanted you to take a look at that we could do with this patient so that we can make a decision on if he's ready to return to practice and if he's ready to return to sport. And I'm going to go through what I would do with them or what we could potentially do with him, depending on some different things. Obviously, this is just a small snapshot of what this patient is, but these are some things that we could potentially do with him in the rehab process to make sure that he is ready to return to practice at this point. So let's create a checklist. Number one, I'm going to have him take the ACL RSI. If he's mentally ready, we have a much better chance at getting all these other criteria met. If he's not mentally ready to return to play, none of this other stuff is going to matter. We want to see that he scores greater than 75% on this exam. But really, the other thing is if he's not ready, and even if he is and he meets 75%, what are his areas of concern? And how can we address that with him moving forward? Rehab isn't going to stop if he returns to practice. He's going to continue to be on that. So what can we do, even if he has some fears, any areas of concern, how can we make him so that he's not concerned with those things moving forward? The other thing, number two, let's evaluate the time since surgery. There's a significant risk reduction with more time to return up until 9 months. He's at 7 months right now. It's greater than 5 months. It hasn't hit 9 months yet. He does have a good risk reduction at this point. He has 1 month left until the season. So we got to kind of weigh the pros and cons of that. Do we hold him out another month and then have him ramp it up for a month before he starts playing so we get that 9-month mark? Or, man, we really got to get him out for the season. We talked with the coach. They want to get him out as soon as possible out on the field again. So there's different ways to measure that. And that's, again, something that we'd have to probably have conversations with him as well as with the coach and the team just to see where they're at in the situation. Next thing I'm going to do, I'm going to use a handheld dynamometer here. I'm going to check the quad and hamstring strength. And it's more convenient than the isokinetic machine, which is not super practical. And it's a little bit more practical and objective than the manual muscle testing. And we want to make sure that we're as objective as possible here so that we can make sure he has the required strength to function. And that's really the important part here. Ideally, we're going to have preseason measures we could use from, let's say, last year if he tore it during the season. If not, let's try to get it early in this rehab process. And hopefully we have some measures early in this rehab process that we can compare everything to. But we're looking for less than 10% deficit of quad to hamstring strength in this case. Next up, we're gonna look at this single leg squat, and this is a basic functional strength movement screen. A lot of times, as a running back, they're gonna have to plant in the ground, and when you think about when you're planting in the ground, that knee almost goes into a single leg squat. So this is going to be a super functional movement that we want to take a look at. We can also add opposite leg movement to assess more balance and stability, add some different perturbations to this to see if he can handle that and maintain balance and maintain good mechanics in this single leg squat. But we're looking at that quality of movement. We're looking at depth and stability. So I want to show you this little video here. Analyze the single leg squat. Again, I'm looking at the knee, I'm looking at the ankle, I'm looking at the foot. Looking all the way up and down the chain here with this. How is his depth? Is he able to stay? You're looking at the frontal plane variations. Is there a varus or valgus deformity with this? Is it controlled at the knee? Is the ankle wobbling all over the place? These are super important things to be considering when we are looking at the single leg squat. Next functional assessment we're going to look at the Y balance test. We're going to be looking at this because I want to see the different positions with the Y. Yes, he's in a single leg squat in a way, but I want to see him in a way adding a perturbation with a reach forward and then a reach diagonally back into each side. Looking at balance, looking at stability. How far is he reaching? And again, we could have some preseason testing that we can compare this to. If not, we're going to want to look for the 90% limb symmetry indexes. That could be the best that we could do in this case. So here's an example, a picture of the Y balance test. You could not use this exact system in this kit. You could just set it up with tape measures on the floor. Have him reach as far as you can, take some measurements, and see where he's at. But you're going to be going forward, you're going to be going backwards diagonally, and then you're going to be going across backwards. Let's get into some hop tests with him as well. Again, good power, as well as more dynamic movements that they're going to have to do on the football field. So the single hop test here, We're looking for distance, we're looking for power, we're looking for quality of movement too. With all of these functional movement screens, we want to make sure the quality of movement is good. And a lot of that is subjective. Unfortunately, there's not a ton of objective data we can get from that. You could use different video analysis and things like that, but I think ideally we have some preseason screening to compare this to as far as how far they're getting, but we want to really look at their mechanics as we're doing this as well. So here's an example. Again, looking at those landing mechanics. How does he land? Where's the knee position while he's landing? And what's the power output? And you can get that with distance and also the eyeball test. Next test that I want to look at is the triple hop test. Repetitive power and stability is important here. And again, looking at distance, power, quality of movement at the knee, but this is also the ability to continuously regenerate that power. And again, ideal, we have preseason screening. If not, we're going to use that 90% limb symmetry index as well. So here's another example of that triple hop. So 3 hops continuously, again, looking for, can they regenerate that power off the ground? And also their landing mechanics with it. Are they able to generate force, but also are they able to absorb force as they land? And the last hop test we'll take a look at is the triple crossover hop test. So this is very similar to that last test, but we're also looking at it in multiple planes. They're going to be crossing over and back. So how can they handle some different frontal and transverse plane movements along with the sagittal plane movement, which is more functional to what they're going to be doing on the football field. So here's an example of that there. Again, watching those landing mechanics, how does he absorb force, but then also the power output. How does he get himself off the ground? Dynamic ability, power, all very important as he's returning to play. And then I want to use a sport-specific test with him, and I'm going to use the T-test in this case. It's, again, very appropriate for football. You're testing him running in different directions, having to stop, quickly move, get up to full speed quick. So testing that agility, that acceleration, that deceleration, that change of direction that he's going to need on the field. We're looking at quality of movement again. Videoing, whatever you got to do, but you want to also look at how he's running, how he's moving. Does he show a deficit on one side compared to the other while he's running? Ideally, we have that preseason screening. If not, use that less than 11 seconds as a measure to make sure that he's passing this test. So here's an example of that T-test. You're running 10 forward, 5 to the side, 10 all the way over here, 5 there, and then 10 back to the start line. Last thing we want to look at, the chronic workload evaluation. So we want to have these athletes build up that chronic workload. So let's make sure that we're building a program that they can have that appropriate workload before practice. So if he's practicing 6 days a week for 2 hours a day, let's build a program that he's doing 6 days a week. And whether we got to work with the strength conditioning staff to make sure he's getting those 2 hours a day, let's do that. Let's make sure he's getting 2 hours a day and building himself up to a point where he can integrate himself into practice right away. If we haven't been doing that yet, I want to start him on this program now so we can do this program for a month and then get him into practice for a month. It's not ideal if he wants to be ready to go for the season, but we want to make sure that he's doing this, or else he's going to go into practice. It's going to be a lot of workload all at once, and now we're risking injury, whether it's a hamstring injury, an ankle injury, or even another injury to the knee. We don't want to risk that, and we can prevent this the best that we can by making sure that he's building up this chronic workload. So, to summarize everything we just went through, don't neglect that mental readiness. Nothing else matters without it. We want to make sure there's an appropriate time for that graft to heal, and we want to make sure they're strong enough to perform these high-quality functional movements, and using these sport-specific functional movements to test them. And a huge thing that I think gets neglected before they return to sport is build up that chronic workload. Have they built that up? Where are they at in that process? And if they haven't built that up, they're not ready to return to sport. We got to make sure that they have built that up before they jump right in, or else they are going to put themselves at risk for more injury there.